The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to today's webinar, Enhancing Care Partnership Support. My name is Alex Kuznetsov, and I'm the Program Coordinator for the National Center for Medical Home Implementation. This webinar is the second of 3 installments of the 2014 How-To webinar series titled Fostering Partnerships and Teamwork in the Pediatric Medical Home. This educational webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau. Before our faculty and moderator begin, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the right-hand side of your screen. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. And now I am honored to introduce you to today's moderator and faculty. Dr. William Schwab is the Professor and Vice Chair of Family Medicine at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. Dr. Schwab is also a member of the Project Advisory Committee to the National Center for Medical Home Implementation, representing the Institute for Patient and Family-Centered Care. Dr. R.J. Gillespie is a general pediatrician and the medical director of the Oregon Pediatric Improvement Partnership. Courtney Whitlock is a parent partner in Dr. Gillespie's pediatric practice, the Children's Clinic. Dr. Jill Reinhardt is a general pediatrician and advocate for patient and family-centered care. Her practice, Hagen, Reinhardt, and Connolly, is a recognized Level 3 patient-centered medical home by NCQA and is one of the best practice examples included in our National Center's Patient and Family-Centered Care monograph. Christy Trask is a registered nurse and care coordinator at Hagen, Reinhardt, and Connolly Pediatrics. She works very closely with Dr. Reinhardt. The presenters have no financial or conflict of interest disclosures to announce. And with that, I will hand it over to Dr. Schwab.
Thanks very much, Alex, and welcome to everyone who is here with us for this webinar. And I want to particularly extend my thanks for your interest in this aspect of enhancing medical home on behalf of the Advisory Committee to the National Medical Home Implementation Center that is presenting this webinar. Our objectives for today are to define the term care partnership support and to explain its effectiveness as part of an approach to providing patient and family-centered care. We also want to describe strategies for implementing successful care partnership support within a pediatric practice and to provide you with concrete examples of how partnership support can be exemplified in your care of children. Next slide indicates that the core elements of a pediatric medical home, and if I could have the next slide. So it begins with a team-based approach. A medical home uses a team-based approach to care. It is often led by pediatricians or family physicians and likely includes nurses or nurse practitioners, physician assistants, your medical assistants, office staff, as well as parents and caregivers and others. A pediatric medical home works with families to enhance their child's well-being. This is not a service that is provided to or for children and families, but rather with them. Families are essential members of the medical home team. Care partnership support is one way to ensure mutual trust and respect, as well as communication between a pediatric care team and its patients and families. Next slide, please. Care partnership support is designed to address family and patient access to quality care and effective communication. An example of care partnership support is when a parent and a pediatric clinician work together to develop a written care plan for a child. The child health clinician makes recommendations about options for the child's care, while the parents talk about how these different options will work for their child and family. Priorities are set. Parent and clinician work together to decide what will be the best approach for the child, involving the child if the child is of an age and ability to be involved. Next slide. A health care plan should be specific to each family's individual circumstance. Families will feel empowered through care partnership support by being involved in their child's medical care. They know their child better than anyone else. It's a partnership. Parents are experts on their child and their family situation, while the care team is the expert in the medical and clinical care arena. Unique health plans made through care partnership support can increase patient follow-through, understanding, and compliance. Results from clinician-parent collaboration are more likely to be improved health outcomes through increased access to support services, specialty care, and educational resources. Next slide, please. Results from clinician-parent collaboration are more likely to be improved health outcomes through increased access and support services, as well as specialty care and educational resources. Because of the additional challenges experienced by families who are refugees, immigrants, or experience homelessness, it is especially important to support and partner with families in these situations to make sure their needs are met, including referring them to available community social services and coordinating with these resources. While working with vulnerable populations, it's important also to take into consideration health literacy. Pediatric care teams need to ensure that parents and caregivers understand the medical information that is being communicated to them, since most health management takes place at home. Taking the time to explain details of the care plan in clear language will go a long way toward patient and family understanding and their ability to follow through with a care plan. Next slide. When implementing care partnership support, first start by making sure that the entire practice staff agrees on the care partnership support policy. Everyone needs to be aligned in this philosophy of care. The policy should be accessible through practice marketing materials or on the website, and if possible, should be displayed prominently in the office. Next, communicate the importance of family involvement in the medical home to families and caregivers. Let families know that their views and questions are always important for both the immediate and long-term care of their child. And finally, encourage patient and family involvement at all levels of the health care plan. Answer questions in a timely manner, be accessible to families, and seek input from patients and families on a regular basis. And now it's my pleasure to bring in Dr. Gillespie and Ms. Whitlock to discuss partnership in the medical home practice.
Thank you, and we appreciate the opportunity to participate in this webinar. I'm just going to talk very briefly about the Children's Clinic. We are a suburban practice in Portland, Oregon. We have a total of 28 providers and a patient panel of about 50,000 patients that are divided between 2 locations. And we've been doing a lot of work with incorporating patient voice into our practice, starting with incorporating some patient questionnaires and then working on a project called Plan Your Child's Well Visit, which helps parents to prioritize their questions and their anticipatory guidance subjects during the course of their checkups. But we wanted to go further, and so we've decided to hire a parent partner about a year and a half ago, and that's Courtney's role. So she's going to talk a little bit first, and then I'll loop back around about how we incorporated Courtney into our practice operations.
All right, thanks, RJ.
Next slide.
I wanted to start off by kind of determining what the parent-provider partnership is. And I really like the definition that was given by the World Health Organization, in that it states that the partnership is a collaborative relationship between two or more parties based on trust, equality, and mutual understanding for the achievement of a specified goal. And what I really like about that definition is that the main components there of the trust, equality, and mutual understanding, it's the foundation of what provides the partnership to be able to meet those specified goals. Next slide, please. Those components also greatly contribute to the value of the partnership. And I find that to be essential in that many parents, they often feel lost if their child has been diagnosed with a medical condition, or if they're young or fairly inexperienced parents. And so when you have that trusting relationship with the medical specialists, the team members, it can greatly decrease those stresses that are put on parents regarding the care that's needed for these children. Additionally, the value of the partnership supports the parents with continuing education and educational resources within the community. And you know, when you have parents that can't meet certain goals on their own, being able to work together really builds that value and that foundation, because you know, as they say, it takes a village to raise these children, and I greatly believe that working together and having these teams is essential in providing the children with the best care overall. Next slide, please. And my last slide here, I just wanted to discuss briefly about the impact of a parent partner in the clinical setting. And from my experience, I truly feel like a vital team member in that I can coordinate with the care team, and that care is centralized around the child's need. It is essential to feel that support and maintain that equality and that understanding of what is the role of a parent partner. The most important thing that I find in being a parent partner is the team development between the parent, the provider, and the child. And not only is the parent-provider relationship important, but the provider-child relationship, because eventually these children go on to have to take on the medical responsibilities of their own, and having the child be a part of the team is also essential for their overall care. In wrapping up real quick, the role of being a parent partner within the clinic also improves and making a difference in the healthcare system, which is greatly needed when these goals are met for the overall care for these children. All right, RJ.
Okay, so on the next slide, I spend about half of my time in pediatric practice and the other half of my time in quality improvement. And whenever I think about involving parents in quality improvement activities, I go back to Don Berwick and some of his maxims of patient-centered care. And particularly the second one, nothing about me without me, because I think that there's a lot of change that's going on within the health system, and so that it impacts all levels of care. And it's important that parents are able to give their input and their advice on all of those different changes that are going on. Next slide. I sort of see the change in the healthcare system as being on 4 levels. There's the environmental context and policy. There's the macro system of changes that are going on within the health plan, the micro system, which is what goes on in the clinic, but then also the patient-provider encounter is undergoing a lot of changes as well. And again, I think that it's important to incorporate the patient voice in each of these levels of change. And certainly within the patient-provider encounter, we've been doing a lot of work with shared care plans as part of our care coordination work, and in that effort are trying to help families to set goals and priorities for their own care. Within the macro system or health plans, our coordinated care organizations within Oregon have been doing a lot of community advisory panels to try to incorporate patients and families into how healthcare is delivered. And within the state of Oregon, we also have the patient-centered primary care home standards that is the policy context. What I'm going to talk today primarily about, though, is engaging the patient advisor in our QI committee. And so that's really the clinic and microsystem change and how we incorporate the patient voice in the changes that we're doing on the ground in our practice. And we really started with bringing Courtney into a specific single project as a parent advisor and decided that we needed her perspective more broadly in our clinic operations. Next slide. This slide describes the steps that are considered when you're adding parents into quality improvement teams, and generally 5 steps that we look at. And the first is really the most important, and that's embracing the idea of a parent partner. And I think the reason that's important is that a lot of providers are really reluctant to let parents see behind the curtain, so to speak, and know that things aren't really perfect within the practice. And I think that there's a little bit of fear and nervousness on the part of providers to let parents know that we don't always have it all together and that we're not necessarily delivering the very best care that we want to, and that we need to do better and that we need to improve. So it takes some time for both parties in terms of parents and providers to recognize that we're really rallying under the same banner, and that's to improve the care for the children that we're taking care of. Which certainly both providers and parents can identify very clearly with. On the next slide, we're just going to talk about what we hoped to get. As I mentioned before, we had a genuine interest in improving the care for our families. Our state's medical home standards include some requirements that we involve patients and families in the operations of our practice. And that actually is a standard that I specifically advocated for in my role in quality improvement through the Oregon Pediatric Improvement Partnership. So I'm happy to say that that's something that the state is looking at very seriously, that all primary care homes here should be involving patients and families in their clinic quality improvement specifically. And really, as providers, we always think we have a good idea of what our parents want and need, but it's really important for us to ask directly. And when you're engaging and partnering with families, it really goes beyond clearing ideas with a parent partner and really involves meaningfully listening to their perspectives and their experiences. We did have some specific questions of things that we want to get help with in terms of what we're doing, what we could be doing better, specifically around access, around how we're implementing shared care plans, and some of the other medical home principles. But we decided that we really needed to be open to the broader perspective and hear what the patient experience is when they interact with us in the clinic. Next slide. So back to embracing the idea, and this really, I think for us involved engaging clinic leadership to illustrate the importance of why we want to have a parent partner, to get everybody on board before we started recruiting. And then also to discuss it with other QI team members and to discuss it with other project team members. So we feel it's important before you hire a parent partner to make sure that everybody who's on the team is on the same page with the idea. And it's important also to remember that this is a new process for most practices, so there may be some barriers that you'll experience and some refinements in terms of how the role is utilized and defined, but that there's a commitment to work through those barriers is an important starting point as well. Next slide. It's important to think about what characteristics you're looking for when you're thinking about a parent partner, and there are a lot of different aspects that we think about. Obviously, we need a parent who's able to commit to the time, so they have child care access when we have our meetings and so forth, that they're confident that they're able to speak up in group settings and not be intimidated by the providers on the team in particular, but also that fits in with the group dynamic in general. Next slide. We also consider that who these parents are parenting may be important for the perspective that they bring as well. And one of the things that we focused on was making sure that we were engaging a parent who had a child with special health needs, just because the experience of that family interacting with the clinic is significantly different and oftentimes more intensive. And I think that oftentimes the parents of children and youth with special health care needs will see sort of the chinks in the armor and the problems with the clinic with a little more detail. It's also important to consider multiple parent partners with different experiences to get a broader parent perspective as well. And for some projects, you may want to consider bringing in adolescents themselves, depending on what the project matter is covering. What we ended up doing was the providers all came up with names of who we thought would be potential candidates for a parent partner, and then did one-on-one recruitment. And that's how we came up with Courtney. She is actually, her children are patients of mine. And I knew that Courtney had good experience advocating for her children and was not going to be shy about speaking up for her children's needs within the context of our quality improvement team. And then we kept the rest of the names for a future project that I'm going to talk about just in a second. Next slide. So I mentioned what we wanted to get, and what we got was exactly what we needed. We got a parent who is dedicated to the improvement of her own medical home in the interest of her children. And we got a perspective that really can't be achieved in any other way. As I mentioned, we do a lot of other what we consider to be methods for engaging patient voice, but having a parent sitting in our quality improvement team really does bring a perspective that we can't get anywhere else. We were able to get some insight into what aspects of care we were doing well with, and some other areas of care where we needed to improve, and certainly a lot of feedback about forms and about the check-in process and what it's like in the waiting room and the sort of things that people are struggling with, just in terms of engaging our advice nurses and so forth. So we get a lot of different pieces of information that we didn't really know were problems. Next slide. And this is my final slide. So just to point out that having a parent on a quality improvement team is just one of many ways that parent perspectives can be heard. Some of the other things that we're working on, we've conducted patient surveys, specifically the CAPS, Clinics and Groups, Patient-Centered Medical Home Survey, which gives us really vital information about our practice. And we have designed some quality improvement projects based on the findings that are meant to improve the results that we got on our self-management support scores, which is really the help that we give to families in terms of empowering them to take care of themselves and to educate themselves on their specific disease processes that their children are experiencing. And we're planning on refielding the survey this next summer and fall to sort of see whether our quality improvement work is working. And we're in the planning phases right now for a parent advisory group that we think will bring in a broader parent perspective, and is a less time commitment for parents as well. A family advisory group or parent advisory group is a group that would meet quarterly, perhaps, instead of 1 to 2 meetings per month, and generally will focus on specific questions or problems that we're having in the clinic. And again, we're going to have access as one of the main questions that we ask. We have done everything we can to have 24-hour phone access for our patients, and we're open every day of the week, and we're open evenings, and still have families that end up using emergency rooms and urgent cares. And so what we're curious about is how we get the message out differently, and that's one of the first things that we're going to ask our family advisory group to work on. We've also been working on specific ways to communicate our quality improvement activities to our families. So we've incorporated some bulletin boards with information in our waiting room, and have done some work on our website and also on our Facebook page to communicate some of the activities that we're trying to improve in, so that the parents have an idea of what's going on in the practice, and also giving them ideas about how to get engaged if they're interested. So that's our bit, so we'll pass it back.
Hi, thank you for the opportunity. This is Jill Reinhardt, and I have my nurse care coordinator, Christy Trask, with me. We have a different practice experience here in Vermont. We are located in Burlington, Vermont, which is a small city and a small state. We have a small practice. We have about 4,000 patients that we serve. We have 3 physicians and 2 nurse practitioners in our practice. Next slide. And today we thought we'd focus a little bit more on the parent partnership that's really within the relationship between the family and the physician by illustrating 4 points today, talking about effective care coordination, the process of care planning and creating care plans, and then a tool we use called care conferences for creating those relationships. Next slide. This is wonderful data from Jeannie McAllister and Rich Antonelli, who have really identified 5 key elements of highly effective care coordination, and they really start with having a key person within the practice who can create that trusting relationship as a care coordinator. In general, Christy provides a needs assessment for the care coordination, creates a bridge for communication and facilitating care transitions between our practice and inpatient, for example. A first step for connecting with community resources and any transitions that child may need between kindergarten and first grade or from a pediatric medical home to an adult-based medical home. Next slide. And within that effective care coordination, Christy's going to speak to some of the functions she provides for families.
Thanks, Jill. So my role as a care coordinator, when we think about providing care coordination, it's really about creating those trusting relationships with families and also with community resources so that we can have frequent, timely, and accurate discussions of care around a child and a family. We are able to use various types of communication, phone, email, care conferences, in developing our plans with families. We are able to have visits and interactions with families. Sometimes those are actually during a physician visit. I will go in and talk to the family prior to the visit or after to wrap things up and again make that point of contact with the family. So we're always creating that relationship and making that connection with families and the patient, if they're old enough and able to. The other aspect I wanted to speak to regarding the care coordination functions is just keeping the goals of the family and child at the forefront of all that we do, that we're able to, when we're developing the care plans and helping families and patients along, that we're keeping those goals in mind and recognizing that the parent is really the expert on their child and giving them access to their medical home through myself and through Dr. Reinhardt.
Next slide. So this is a partnership care planning model that we've been working with Jeannie McAllister to put forth, but essentially recognizing that we no longer just have an office visit, but we have this ongoing relationship, different steps. And the first real step is to identify the needs and strengths of family and hold family-centered discussions, complete multifaceted assessments. We'll talk about an eco-map as one of those assessments. Secondly, as Christy spoke to, we build these essential partnerships that set personal goals, so goals that the family may have, and medical goals, and they may be the same, they may be different, but we share in the decision-making around those goals. We also will link to specialists and community service providers as we build those essential partnerships. And the third is to actually develop this concrete care plan that's shared. Within it, there's a medical summary of medical needs, but we also have what we call negotiated next steps or actions, things that hold us accountable. So Christy's going to call so-and-so about X. I'm going to make a referral letter, and the family is going to enroll Johnny in such and such. And the third part of that care plan are emergency plans that are so key for things like seizure planning and asthma exacerbations. And finally, somehow through this care planning process needs to have a bit of oversight. So Christy will check in periodically, even outside of a patient visit, to make sure that those next steps are being fulfilled. And we monitor that and are able to evaluate, update, and then renew the plan of care as we need to. Next slide. This is a bare bones view of one of the tools we use as we assess our families. It's called an eco map. It comes from our social work colleagues. It's also arisen in the literature from families as well. But it's been a tool that's helped us to really identify gaps in services for family, and also to help physicians appreciate the complexity of families who have children with special needs. So you'll see bubbles around financial support, such as insurance, child care subsidies, community grants, a school with early education all the way up to post-high school. Child care can be an important source of support for families, and then informal supports as well. Next slide.
Sure. This is actually an eco map of a family in our practice, and as you can see, it's very colorful and very full. And just to give you a sense of the supports that this family identifies as important and as sources of support for them. In the yellow is all of the medical supports, as you can see. That can be anything from a specialist, the neurologist, to a vendor that they use for equipment. The purple is family, and those are family supports, whether those are church supports. She's got Therapy Dogs of Vermont in there, and she's also finding support from her schooling, from Champlain College. And then in green are the state education and community support. So those represent housing. Those also represent mental health supports like Howard Center, SSI, et cetera, and then the school as well.
And this looks a little overwhelming when you first look at it, but it can actually be a real helpful tool that we use as part of the care plan as a thumbnail summary of what families have in place. Next slide. So another tool that we use to create these partnerships are care conferences. And Christy and I both attended care conferences that have been very beneficial, and ones that maybe weren't done as well. And so as part of being effective, we really have a semblance of an order for these team meetings. They can bring in people from, we certainly have, they're typically led by family and the medical provider. We have an agenda that Christy will often set the agenda before the conference, but we open it up for people to add things to the list at the beginning of each care conference. We make sure that everyone's introduced to one another. We may have community providers, a speech language pathologist. We may have a subspecialist who's calling in to talk about an ophthalmology report for 10 minutes. We set roles and mental health providers as well, exactly, in the team. So we set roles: who's going to take minutes, who's going to keep us on time tracking, who's going to be a jargon buster for the acronyms that are invariably thrown around between the different disciplines. We always start our care conferences with the family's strengths, and often that revolves around reviewing what's special about that youth that we're talking about today. And we have many minutes for discussion, and we have these things are recorded, and Christy's typing up as we go along so that people can leave with an updated care plan with identified goals, next steps, and accountability for those next steps, and a next conference date should we need one. We kind of make an assessment together as a team whether we need a medical-based care conference or not, but everyone leaves with this shared care plan. Next slide. So we thought we'd just discuss briefly two care studies, we call them, of situations where the care conference and care planning model has been particularly effective. The first that came to mind for us is a little boy who's 13 who has autism, is nonverbal, has significant self-injury with picking behaviors, causing even scarring, and polydipsia, drinking anything that he can get his hands on, water especially. Parents whose family has really gone above and beyond the capacity of many families to deal with this at home were struggling with safety. He would bolt, and certainly the middle school is unable to educate him as to their best ability and to keep him safe. And there are many medical issues of skin infections, enuresis, and sleep dysfunction, which are complicating this particular team. Next slide. So this, in terms of what we each bring to the table, I think is important. So, we really looked at what our overall goals were, what our care planning negotiated actions are, and then the ways that we can assess whether those next steps actually were effective or not. So a big goal, of course, is less self-injury, for example. So we're able to fast-track a psychiatric assessment and engage the psychiatrist to talk with our school and with the behavioral interventionist who are working with this young man to really improve a common ground for behavioral plan, so that behavioral planning was being done at home and at school in similar ways. Another goal is to improve school attendance and education support. We got people on the ground looking for alternative school placement. The family had a couple of ideas that came to the table, and the school team was actually open to exploring alternatives as well, which was wonderful. And finally, medically, he had many repetitive behaviors that really were a sign of obsessive-compulsive disorder. And to improve pharmacology, improved wraparound services and behavior plans, we were able to cross those silos of mental health, developmental disabilities, even our state supports of CSHN and the school to bring people together to make out-of-the-box decisions about how to best assist this child. Our second, next slide. Our second is a younger girl, Mary, who's 4 years old, who had significant self-injury and a diagnosis of tuberous sclerosis, which can be a progressive condition. Seizures, sleep dysfunction, and was when the time we met the family was heading for an inpatient psychiatry hospitalization, again for safety reasons. And this despite having as much wraparound dollar services that we offer in Vermont. Respite care with a loving family to help give their primary care family support, and an intricate team of multidisciplinary medical experts around tuberous sclerosis at Mass General. Next slide, please. And her seizures really were less of a concern in comparison to many of the behaviors of self-injury, tantruming, hurting parents, hurting herself. And she had many, many strengths. She is very engaging, strong parent involvement, and lots of expertise around Mary and other medical parts of her illness. A loving respite family, as I said, that provided a lot of support. And Mary herself has had some real verbal and cognitive strengths that we were able to engage to help in her care overall. Again, next slide. We brought this family together with people on teams that don't usually come into the same room together. So, and that made a huge difference in managing her care. So the big goal, the first one, was less crisis intervention, and between co-management from psychiatry and our medical home, and being able for me to have a kind of a direct input subspecialist, we were able to manage medication to a place where the outcome was less need for police and mental health crisis support. We were able to engage a behavioral interventionist who doesn't typically go out to this part of the state, but because of the needs of this child, we were able to make that exception, and he was able to go and observe Mary at home and at school and make lasting behavioral interventions. Yeah, and Christy, please.
And I must say that, you know, as we continue to learn and continue to hold care conferences and care plan around children and families, community resources such as schools and mental health and all the agencies that we partner with to serve children and families are so willing and so happy to attend team meetings and be part of the team that it's really, they really help us to make what we do easier and make better outcomes for families, because the idea of partnering together really, it really can be very, very successful.
Next slide. These are principles that have been put together by a national panel of experts, including and led by family representatives, but really are the principles for successful use of this shared plan of care. You want to talk first?
Sure.
Yeah.
So when we think about the shared plan of care, it's really about the children, youth, and families being you know, actively engaged in the care with that clear and timely communication among their medical home team. that providers and team members base their patient and family assessments on really understanding the family and understanding the child, knowing what their needs are, and asking them what they want and what their goals are. Those can be, related to history, related to cultural beliefs, and just overall preference. And then that youth, families, and health providers and their community partners have strong relationships that are really characterized by mutual trust and respect for one another.
Next slide. Yeah, so these family-centered care teams, we use this plan of care that's characterized by shared goals and negotiated actions. And all partners understand the care planning process. Their individual responsibilities, so we know what we are supposed to be doing and what we're accountable for. The team then monitors the progress against goals and provides feedback and adjusts the plan of care as necessary on an ongoing basis to ensure that it's really effectively implemented. And team members anticipate, prepare, and plan for all transitions. And that's where families ask us to be leaders, to help them identify what's coming down the road, much the way that we provide anticipatory guidance for child development, but perhaps a little different with our children with special health care needs. And next slide, please. And this is a slide that's put together by one of our family parent partners who we do some teaching with. I'm not sure which I like better, the smile on the face, the choose happiness, or the I dig dirt. But her point about why this is important for her as a family-centered medical home is that it creates an opportunity for the family to build this trusting and collaborative relationship with the pediatrician and the office staff. That she identified care coordination providing a smooth facilitation among all members of her child's care team. And finally, as a comprehensive source of medical history, which sometimes I think is what is the original source of our practice space. And that's the end of our slide. Thank you very much.
So this is Bill Schwab again, and if I can have the conclusion slide there, I want to thank our presenters for the really remarkable work they're doing and for their considerable ability to present it in clear and understandable terms so that all of us can think about how we can be enhancing the work that we do in practice. I think clearly the bottom line is that incorporating care partnership support helps to ensure family caregiver and patient involvement within the pediatric medical home, and that implementation of care partnership support results in improved health of the child and improves future care goals. If I can have the next slide. The National Center for Medical Home Implementation is a powerful resource for clinicians who would like to do this kind of work in their own practices. The National Center provides a variety of tools and resources and links to assist practices and clinicians and community members and caregivers with care partnership support. So you'll see the link on this slide, which can be visited to provide more information. I'd also like to point out that the National Center recently published a monograph titled Positioning the Family and Patient at the Center, which is really well done and provides examples of pediatric practices and the specific strategies they've used to enhance care partnership support. Often low-tech, straightforward, collaborative approaches that have improved the way that they deliver practice. So visit this link for additional resources and tools to help your practice. And then I would add that Family Voices is an outstanding organization which works to place families at the center of healthcare, and their website provides a large collection of resources for practitioners and families. Or you can check out the National Initiative for Children's Healthcare Quality, which provides a great resource called Powerful Partnerships, a handbook for families and providers working together to improve care. This publication provides tips for multidisciplinary pediatric teams on partnering for families of children with special health care needs. And finally, the Region 4 Genetics Collaborative also publishes a wonderful resource which helps parents to better understand the medical home concept and to work within it to partner with their pediatric providers. Next slide. This webinar series is based on a series of educational videos developed by the National Center for Medical Home Implementation. The videos focus on team huddles, care partnership support, and family advisory groups. So again, visit the National Center for Medical Home Improvement website, YouTube page, for a full range of videos on pediatric medical home. They really can be great resources for your staff and your patients as you're doing transformative work within your own practices to enhance the lives of patients and families and to increase the satisfaction of clinicians and staff members in the care they provide to strengthen collaboration and care partnerships. So thank you for your attention. We do have time for questions, and Alex is going to moderate this segment of our webinar.
Thank you so much, Dr. Schwab, and our faculty members, Dr. Gillespie, Courtney, Dr. Reinhardt, and Christy, for your extremely valuable presentations. We do have some questions that have been submitted by audience members. I want to remind everybody that if you do want to ask a question, you can type it into your question box on the right-hand side of your screen. So the first question is for Dr. Gillespie and Courtney, and it asks, how many parent partners do you have for your 50,000 patients, and how are your parent partners compensated?
So right now we have one. For our family advisory groups, we are planning 4, which would be about 6 to 8 different family advisory groups. And part of the reason that we're planning 4 eventually is that we want to have one for our English-speaking families and one for our Spanish-speaking families, but then also one from each of our sites. In terms of compensation, our intention was to compensate Courtney on an hourly basis. And we got some guidance from our Oregon Center for Children and Youth with Special Health Needs. Their family-to-family network does training on recruiting family partners. And generally, the thought is that you give enough reimbursement not only for their time, but also to cover any child care expenses and so forth. The going rate, according to Ocean, is somewhere between $20 to $25 an hour. And for our meetings, we usually have 2 a month. Courtney's not been invoicing us. I'm not sure why that is.
I like it so much.
So that's our intention. And with the family advisory groups, we're still working out the details on that. Our plan is to have those during the day when kids would be generally in school, so that the parents hopefully have a little bit more flexibility. But we're also exploring right now providing child care for those kinds of things.
Great. Thank you, Dr. Gillespie and Courtney. The next question is for Dr. Reinhardt and Christy Trask, and it concerns care conferences. So there's a couple questions concerning this care conference concept. First of all, how long are the care conferences, and how do you go about scheduling them during the workday? Are they part of a medical visit, or are they scheduled separately? And finally, are they offered to all children and youth with special health care needs, or just to demanding cases?
So, yeah, we spend an hour, typically 60 minutes. Sometimes if there's a family that has 2 children that we're discussing, we do maybe do 90 minutes. That's happened on occasion. And there is a certain level of complexity that rises to the need for care conferencing. And sometimes that is the topic that comes through Christy's interviews with the family, or if it's a family that we know is having a major transition coming up, a complex orthopedic surgery for a child with cerebral palsy, for example, we may say, oh, this is a moment where we need to bring the whole team together to care plan around and problem solve around. But certainly we keep it open so that, like a care plan, any child can have one if it's needed to happen. But it turns out we do them at noon, 2 days a week for me. And my partners choose different days of the week, so I do Tuesdays and Wednesdays, and they've been doing Thursdays and Fridays. So, and I think there is this moment where we may do a care conference for a particular family once a quarter. That would be the highest level, and often it's more like once a semester, so twice a year. And then often there are flares, and then they kind of calm down, and we don't need them as frequently.
Great. Thank you, Dr. Reinhardt and Christy. So the next question is for Dr. Gillespie and Courtney. And the question is, what is the response rate for your parent survey, your CAP survey?
We had about a 35% response rate, which for CAPS is actually fairly high. And part of what we have done in the past, because we've done other patient surveys with our families, and one of the things that we have done is put up posters ahead of time in the practice for a couple of months to say, hey, we're looking for your feedback, so that when they get the surveys, since it's random samples, they're not surprised by it, and they're more willing to fill it out. So I think that one of the important things, if you're considering doing a patient survey, is to do a little bit of preparatory work. One of the sort of barriers that we ran into, we did use a certified vendor for our CAP survey, and so the envelopes came from Michigan, and so our families were like, what is this? Is this really from you guys? And so having a little bit of pre-preparation for the families helps with the response rate significantly. So that, again, we had in the mid-30s, and that for CAPS is high because we did a little bit of prep work ahead of time.
Great. Thank you, Dr. Gillespie. The next question is for Dr. Reinhardt and Christy, and it says, are there any pediatric tools to score the complexity of care coordination / care management for patients?
We use something called the HOME score that was developed through Exeter Pediatrics in New Hampshire, and we have the H stands for healthcare needs, right? And the O is for office use. The M is for medical conditions, and E is sort of extra equipment, extra needs, and S is for psychosocial. And you essentially get 2 points for each of those. So that's a wonderful score. You actually have that on your National Center for Medical Home Implementation website too, and it works well. So for example, you can have a child with maybe one medical condition, asthma, with a very high score because of the extra complexity that family may require support for.
Great. Thank you, Dr. Reinhardt. So the next question is for all of our faculty members, and it asks, how do you support all of your care partnership efforts financially?
That's a great question, and that's sort of one of the I think burning issues. We have a care coordinator in our office as well, actually 1.5 right now, and so we had when we set up our care coordination program within our practice, because of our size, obviously we could probably have 8 full-time care coordinators, and that would all come right out of our overhead. And so what we did instead was we looked at care coordinator functions and then decided which of those competencies lie within the practice teams and which ones needed to go to a specific care coordinator. So our care coordinator really only cares for our most complex kids, and the kids with asthma and with ADHD and other conditions like that are actually managed within the practice. And so we developed protocols and workflows for our practice teams to handle a lot of the care coordination needs, which keeps the cost down a little bit. But for the most part, when you're talking about care coordination services, it comes out of the overhead for us.
Yeah, that's very similar to our experience as well. We do have a unique Vermont relationship with something called Blueprint for Health, which as a patient-centered medical home, it gets us access to a community health team, and we have negotiated within the county that we are in for 3 pediatric practices to carve out services that are pediatric-based, and one of those roles is some dollars to support care coordination that is practice-based for those highly complex kids within our practice. So that's a new avenue. It's very difficult to negotiate with payers for things that you, quote, are already doing, unquote. So so for practices that are coming on board and learning about care coordination, that's, I think, a powerful place to look for resources to support that role.
This is Bill Schwab, and I'll talk about how we deal with this in our what is a large multi-specialty practice in the academic medical center. So we have 1,200 different providers, although that doesn't represent 1,200 FTEs across the multi-specialty group. It's more like 700. I'm on the board of directors of that organization. We went to a panel-based reimbursement system for our primary care doctors so that the focus was really on how can we best take care of our panels of patients and not on working through an entirely visit model, although there's a small amount that is, there are various percentages that can go for that sort of reimbursement. So from an individual compensation point of view, panel-based reimbursement can be an asset, and we also made that a weighted panel-based reimbursement based on the complexity of care, so that if you're Dr. Hagen or Dr. Gillespie and your practice is dense in children with special health care needs, that would be figured into the way your panel is configured. Along with that, as an organization, we use tools to identify the highest utilizing, highest need individuals in terms of what their needs would be, and provided a complex care management resource that can be used across our practices to really focus on and connect with those patients and families. And this has been supported in part by our payers, who recognize that it's win-win if we can partner effectively with patients and families in ways that help them to get along and get the best outcomes while being prudent about utilization. If we can do that in a way that is part of your panel-based reimbursement, so the physician isn't sort of penalized in terms of the time they spend, because some of the time that they have is to do care that is non-face-to-face care, and that's figured into their reimbursement formula. So if we can do that in a way that isn't extra for the doctors, doesn't increase costs, and allows families to be home more and deal with the things they want to deal with as families while their children are healthier, that's a win for everyone, and we look for that sort of alignment.
I guess the only other thing that I would add is that the theory behind doing some of the care coordination efforts and dividing that out in the practice is the idea of having everyone in the practice practicing to the top of their license. So it's very expensive for a physician to spend a lot of time doing paperwork, chasing down medical supplies, and so forth for families. And so in theory, a care coordination program would help a provider to see more patients to protect your bottom line as a practice. So that's just the other consideration to think about is it may be an expense out of your overhead, but it may create efficiencies in your office that you make up for that in other places.
Great, thank you, everybody. Unfortunately, we are running out of time, but once again, I want to thank all of our audience members for your questions, and our moderator and our faculty. This webinar will be recorded, and the slides and any unanswered questions will be archived for weeks from today on the National Center for Medical Home Implementation website. Additionally, you will receive an email after this webinar that will be asking you to complete an evaluation. This evaluation survey will only take a few minutes of your time, and we would greatly appreciate it if we could get your feedback. So registration for our third webinar is now open. It's titled Starting and Supporting Family Advisory Groups, and it is scheduled to take place on Thursday, April 24th at 11 a.m. to noon Central Time. So you can register through our website. There is a link on our homepage. So thank you, everybody, again for your participation, and we are looking forward to seeing you all next month.